Respected Vice Chancellor Dr. Achal Gulati sir, Pro Vice Chancellor Dr. V.K. Kapoor sir, Medical Director Dr. Jaiswal, other dignitaries, my colleagues and dear students. Before starting CCR, I will give you the brief introduction about our department. Department was established in 2015 and DM Neonatology started in year 2021 with admission of 2 DM residents every year. And 2 batches have already passed out. And our alumni are doing very well outside at their places. Dr. Aril is consultant at Ludhiana. Dr. Jyoti is assistant professor in D.Y. Patil Medical College, Pune. And our recent pass out, Dr. Ankush and Dr. Sahaj have been selected and as registrar in various hospitals of Australia. Our faculty members along with me are Dr. Saurabh Singh, Professor, Dr. Arjun Verma, Associate Professor, Dr. Satyen K. Hamrajani as Senior Consultant and Assistant Professor. We have a 23 bedded NICU at present, where we are catering all high-risk newborns, including preterm 25 weeks onwards, and having a facility of neonatal transport with neonatal transport incubators. We have a state-of-art equipments like 5 high-frequency ventilators, 4 non-invasive ventilators, but our policy is to avoid any invasive procedure and to keep non-invasive to avoid ventilator-associated pneumonia. We also have the facility of point-of-care ultrasound, where all sorts of focus is done by our own faculty and residents for every case, almost every case. Total parental nutrition facility is also available in our department, but our motto is to start full feeds as soon as possible, even in preterms from day 1 if there is no contraindication, as avoiding lines or cannula avoids the major source of sepsis. We are very lucky having Amrit Milk Bank, that is human milk bank, in our own institute, which was established in 2016, and 250 units per month are provided to us. That is the boon for our tiny newborns in NICU. We are also having a lactation consultant, and after her joining, there is a tremendous improvement in breastfeeding practices and human milk donation. As far as academic activities are concerned, in last 5 years, we have published in national and international reputed journals about 19 papers, and we have attended conferences. All faculty have been invited as either speakers or panelists in at least 23 conferences or CME last year. We have arranged guest lectures by eminent national and international faculty. Besides regular day-to-day academic activities, we are also doing work outside also as a national faculty. We all 4 are national faculty, either in basic NRP and or advanced NRP and BLS, and participating in organizing such programs periodically as faculty members. These are certain success stories of us which are covered by media. We have organized certain national workshops on advanced neonatal resuscitation and neonatal procedures. Neonatal resuscitation workshops are a regular feature of our department, which are simulation and problem-based for learning. We organize every year breastfeeding week in August and newborn week in November to spread the awareness in masses, students and nursing staff and paramedics. Besides this, nursing education is a regular feature of our department. Maybe because of that, when during last breastfeeding week, and NNF Jaipur organized nursing fees, where about 10 teams participated from various hospitals. We are proud to say that our team was declared winner. There is a steady increase in the number of OPD cases in last 5 years, and same is true for IPD cases. But our best achievement, rather the moments of real happiness, are when we see these little achievers who were born less than 1000 grams prematurely and fought their battle against all odds and came out as winners with neurodevelopmental intact survival. Especially I will like to mention these two newborns who were born around 500 grams and now around 4 years of age and doing very well. Thank you. Now I will invite our first year resident Dr. Kanika Khanna to proceed for CCR.
Thank you, ma'am. Good morning to all. Today's topic is From Brink to Breath, Surviving Neonatal Collapse. I am Dr. Kanika Khanna, first year DM Neonatology resident. We will begin with the antenatal history. This was a 30-year-old primary gravida female who had conceived spontaneously. She was referred to our hospital at 33 weeks of gestation in view of preeclampsia. Antenatal ultrasound showed fetal growth restriction associated with oligohydramnios and deranged Dopplers, suggesting placental insufficiency and fetal compromise. Serial Doppler surveillance was performed during the antenatal period. At around 28 weeks, we can see the umbilical artery pulsatility index was noted to be above 95th centile, indicating increased placental resistance. This was followed by biweekly Doppler monitoring. At 33 weeks, there was a reduction in the middle cerebral artery pulsatility index to below 5th centile, suggesting a brain sparing effect. There was also reversal of the cerebroplacental ratio, which indicated significant fetal distress. At this point, I would like to invite Dr. Sarika Yadav, Assistant Professor and Fetal Medicine Specialist from Department of Obst and Gynae, to discuss the antenatal Doppler findings and the fetal surveillance that guided the perinatal management in this case.
Good morning all. I am Dr. Sarika Yadav, a Fetal Medicine Specialist and Assistant Professor in Obst and Gynae Department. So a primary gravida at 33 weeks came to our for an ultrasound assessment. On examination, there was oligohydramnios. AFI was 4.5 centimeters. The fetal biometry was reduced. All parameters were less than first centile. Effective fetal weight was 1142 grams, which was also less than first centile. So the findings were suggestive of early onset fetal growth restriction. On Doppler assessment of the umbilical artery, there was absent end diastolic flow. So this is a normal Doppler waveform which is expected in any pregnancy during this gestation. So during a fetal cardiac cycle, there is forward flow both during the systole and during the diastole. But if there is any placental resistance, this diastolic flow starts decreasing and at the end it stops. So in this pulse wave Doppler of the patient, we can see that there is only systolic flow, whereas there is no diastolic flow as shown by the red arrows. So this is known as absent end diastolic flow, and this finding indicates severe placental insufficiency. So at this stage, only 50% of the placental villi are actually adequately perfused. Because of this increased resistance, there is decreased supply of oxygenated blood to the fetus, due to which the fetal body starts working in a compromised manner. So it maintains the blood supply to the vital organs like the brain, adrenals and the heart, whereas the blood supply to the less vital organs like kidneys, intestines and the peripheries is reduced. This phenomena where the blood supply to the brain is preserved, rather it is increased, is known as brain sparing effect. So this is the normal, on the left side is the normal waveform Doppler which is expected. So we can see the systolic component is 3 times of the diastolic component, whereas in this patient the diastolic component is, increased. So this can be subjectively assessed by the PI or the pulsatility index, which is lower than the 5th centile for this gestational age. The Doppler, uterine artery Doppler also showed an increased resistance with the mean PI more than the 95th centile for the gestational age. The ductus venosus is the last vessel to be affected in this sequelae of FGR. In our case, the ductus venosus flow was normal. So the final diagnosis was a 33-week, 4 days pregnant female with oligohydramnios, fetal growth restriction with Doppler changes, particularly absent end diastolic flow, which comes in the stage 2 fetal growth restriction by the Barcelona staging. So in view of the above findings of ultrasound, delivery was advised. The patient had received antenatal steroids already. To discuss the further birth details, I would like to invite Dr. Kanika from Department of Neonatology. Thank you.
Continuing with the birth details, considering the progressively deranged Doppler findings and increased risk of fetal compromise, the obstetrics team decided to proceed with a planned cesarean section. Prior to the delivery, the mother had received a complete course of antenatal corticosteroids in the form of intramuscular dexamethasone, administered 12 hours apart for fetal lung maturation. The baby was subsequently delivered by cesarean section at 33 weeks of gestation. The baby cried immediately after birth and did not require extensive resuscitation in the delivery room. Birth weight was 1,290 grams, which was consistent with prematurity and fetal growth restriction. The Apgar scores were 7 at 1 minute and 8 at 5 minutes, which indicates satisfactory initial adaptation after birth. Following stabilization, the baby was shifted to NICU for further preterm management care. Here we can see this slide is representing the postnatal growth evaluation of a preterm female infant using the Fenton 3rd generation preterm growth chart. The chart is the standard tool for assessing size and growth in infants who are born before 40 weeks of gestation. The red dots on the Fenton chart, as we can see, correspond to the weight, length and head circumference. Birth weight being 1,290 grams is lying below the 3rd centile. The pointer is not working. Plots below the 3rd centile for gestational age. This indicates severe low birth weight. The length is 37 centimeter, which also lies below the 3rd centile. The length lies below the 3rd centile, which also indicates there is growth restriction. Head circumference being less than 26 centimeter is also lying below 3rd centile. When all these 3 parameters fall similarly below normal, we consider it a symmetrical growth restriction because the weight, length, head circumference are similarly affected. This pattern is consistent with symmetrical intrauterine growth restriction rather than asymmetric where the head sparing occurs. So based on the plotted data, the infant is classified as preterm and small for gestational age with symmetrical IUGR. Both together is a double jeopardy. Contrary to our NICU policy to start full enteral feeding at day 1 of life for more than 28 weeks, we had to keep this baby nil by mouth. Reason being, in cases of deranged Doppler, there is a decreased flanking circulation and increased blood supply to vital organs. This can make the gut more vulnerable to ischemia, poor motility, feed intolerance as well as NEC. In newborn babies, securing central line is important as the small veins run off easily. Now in newborns, securing the central line is a bit different from securing it in adults as well as in pediatric age group. We secure it through the saphenous vein, and since it is peripherally inserted, it is called peripherally inserted central catheter, that is PICC line. For our baby, one of our residents secured PICC line in the first 24 hours of life. At the time of securing line, we do a strict vigilance. Who is securing the line? Had they washed their hands? Was aseptic technique followed or not? This is an entire checklist which we follow at the time of procedure. Not just this, we follow a maintenance checklist after inserting the line in order to prevent collapse. We are very grateful for the availability of laminar airflow system in our unit. We are able to prepare total parenteral nutrition under strict aseptic conditions after proper mixing of fluids. The laminar airflow provides a controlled sterile environment, thereby it minimizes the risk of contamination during TPN preparation, that is total parenteral nutrition. In addition, our unit is equipped with ultraviolet radiation, which further helps in maintaining sterility and infection control standards during this preparation. For the first 48 hours of life, the baby was maintained on total parenteral nutrition to ensure adequate nutritional support, while the enteral feeding was deferred. After 48 hours, minimal enteral nutrition was started, that is 20 to 25 ml per kg per day, and enteral feeds were gradually advanced between day 2 and day 5 of life based on feed intolerance and clinical stability. We are very fortunate to have a dedicated human milk bank in our institute, which plays a very crucial role in meeting the nutritional requirements of extremely preterm and very low birth weight babies. We are proud to share that formula milk usage in our setup is minimal, which has been made possible because of the support of the state-of-the-art milk bank. Baby was doing well till day 5 of life, following which from day 6 of life there was onset of clinical instability and rapid deterioration in condition. I would like to invite Dr. Siva Kumar, DM resident, to elaborate on the clinical course and rapid decline.
Thank you, Kanika. That was very well put. I'm here to carry on forward the baby's course further in the ICU. So, baby was doing well till day 5 of life, and on day 6 of life at 6 am rounds we had seen that the baby's clinical parameters were normal. However, at 8 am further bedside examination had shown that the baby was in compensated shock. You can look at the heart rate was touching 200 beats per minute, as well as the respiratory rate 88 cycles per minute, and BP was 38, which is normal for gestational age. So we had done a system-wise examination then that had shown a deteriorating vital trend. In a suddenly crashing newborn, blood gas is of utmost value to determine the status and a clue for the cause. So you can see that this gas is suggestive of metabolic acidosis with high lactates. So as there was a rapid decline, the first hour of deranged vitals is the golden hour, and this requires meticulous management. In adults you would be managing ABC, however in newborns we go for TABC. So for temperature, we had isolated the baby, we had optimized the temperature in the warmer and with optimum humidity. And for airway and breathing, we had taken the baby on invasive mechanical ventilation with appropriate pressures and FR2, and we had asked for chest X-ray and abdominal X-ray. For circulation, we had inserted a new central venous line, and we had also secured an arterial line for frequent gas sampling as well as for invasive BP monitoring, which happens to be the gold standard in shock management. And we had upped our vasopressor dose to 0.2 mic per kg per minute, and second most importantly, we had given an initial fluid bolus, and most importantly we had started antibiotics, meropenem. So at this point I'd like to ask pediatric PGs or anybody who has ever worked in maternal child health care to come up with differential diagnosis. We'll go about ruling out our differentials. So we had started our hunt for the cause promptly. We had done a bedside point of care ultrasound echo. This had shown that the arch of aorta was normal, so coarctation of aorta was not likely. And we had also done a neurosonogram, and you can see that in the lateral ventricles sagittal view there was no bleed seen over here. And over here I'd like to point out that point of care ultrasound, it's not just useful for structural anomalies, differentials, but also you can pinpoint any shock due to any cause. There's also a functional aspect to this. So even before we had received the reports, or even before probably the sample has gone to the lab, we had our first clue that was baby was in compensated shock. There was tachycardia and high cardiac output, so baby was likely in late onset neonatal septicemia. The next differential I wanted to rule out was NEC, and our X-ray, you can see that the chest X-ray there was reticulonodular opacities, but more importantly on the abdominal X-ray you can see that there is no feature suggestive of NEC, and later you would see that labs also showed a normal sodium, so NEC was not likely, and bedside ultrasound was also done, that was normal as well. There was no pneumatosis intestinalis. So as far as inborn errors of metabolism, I would have thought of congenital adrenal hyperplasia, but then again, because we had a preterm baby, sudden deterioration and high anion gap metabolic acidosis, and there was also an abnormal antenatal Doppler. However, our serum ammonia was normal, and given the antenatal history and the general physical examination, there was no ambiguous genitalia. It was a preterm baby, no syndromic features, and there was no. And I'll share further points. So salt wasting was not noted. You can see the labs over here. Apart from slight uremia, all the other labs were more or less normal. Sodium was normal, potassium was normal. This would go against congenital adrenal hyperplasia. So we have ruled out coarctation of aorta, NEC, IEMs, and there was no IVH as you had seen in the NSG. We are left with late onset neonatal sepsis. So further day 6 of life, we had our labs appropriately timed, and we had neutropenia and thrombocytopenia as well. So the inflammatory markers were elevated as well, hence we had done a lumbar puncture as is the protocol in late onset sepsis. The findings are suggestive of meningitis. So one thing I want to note that in a suddenly crashing newborn, you would want to suspect a gram-negative bacillary septicemia. So over here we have late onset neonatal septicemia with the baby in septicemic shock with possible gram-negative bacillary sepsis. So for this we were already giving meropenem, so we had added on colistin for gram-negative bacillary coverage as per our NICU antibiogram, and we had upped the vasopressor dose to maximum 0.5 mic per kg per minute. And also in newborns, the guidelines suggest that when the first vasopressor is at its maximum dose, we should also add a steroid in order as an adjunct in the management of shock. And we had taken the baby NBM due to shock as well, and urinary catheter was inserted for strict input-output monitoring. Later on day 7 of life, we had seen that the baby had further deteriorated, the heart rate was rising, and now the BP also had started to fall well below 35 mm². So within the next 24 hours, there was also poor perfusion index, and baby was also started to go to renal shutdown, as you can see. Baby had oliguria and capillary fill time, which was already prolonged. This was starting to deteriorate even further. So we had done our gases. You can see that the gases show dip in pH and dip in base, increase in base deficit, and marginal increase in lactates. So simultaneously baby's ventilator requirements were increasing as well. You can see that the baby's FiT requirement was steadily increasing, and baby's mean airway pressure requirement had gone to more than to 12. So in PSU and NICU, mean airway pressure of more than 12 we usually take the baby on rescue mode of ventilation. We are taking the baby on high frequency oscillatory ventilation. A MAP of more than 12 means it's no longer tenable to manage on conventional mode of ventilation. So further lab showed further deterioration. There was neutropenia, thrombocytopenia, and there was also coagulopathy. However, there was no bleed on neurosonogram. So we had added colistin, steroids were added, and so management. Now even on adrenaline 0.5 mic per kg per minute as well as steroid adjunct, BP was starting to fall and baby's shock was starting to get decompensated. So this so we had added on dopamine at 20 mic per kg per minute. Also, even on dopamine, baby's BP was not being maintained, so we had added on vasopressin. Anybody who has ever worked in an ICU knows that vasopressin is usually used as a last resort. We had also given blood products as an adjunct. So since we have a sick baby, might as well do a neonatal sequential organ failure assessment. It's almost the same as QSOFA for adults. So this was developed as a tool to assess newborns in late onset sepsis. Absolute values and changes in NSOFA scores are associated with increased likelihood ratio of mortality. Score of 2 point means a twofold increase in risk of death. 6 points is fourfold increase, and 10 points is an 81% chance of mortality. And our baby had higher scores in all the domains. So score of 15, risk of mortality more than 80%. So we have a preterm baby with field growth retardation and refractory septicemic shock, not responding to conventional antibiotics. We had started the baby on, if you can recall, meropenem and colistin, and mods was setting in as well. So this was a situation to panic, as this baby is sick anyway, but good antibiotics were not working, and what if this could be the start of a septic outbreak in the NICU. So on till next day, baby had shown no improvement on colistin. On day of life 8, microbiology department had informed us of gram-negative bacillus growth on culture. We had no time to wait for the full antibiotic sensitivity testing report. Newborns rarely give us the time to act, and they don't have the luxury of time. We were quite perplexed in our consideration for as to what antibiotic needed to be started next. So we had sought Dr. Yash Kathod's advice. I now invite him to carry on the case forward. We are really lucky to have him. You know that he is one of the only 2 infectious disease consultants in this city.
Thank you. Good morning, respected dignitaries and dear colleagues. So our department got reference on day 7th of life. The patient was admitted in NICU for past 7 days. The baby was preterm with small for gestational age and IUGR. Born of LSCS at 33 weeks of gestation due to preeclampsia and placental insufficiency. There was a clinical deterioration from day 6 onwards with working diagnosis of late onset neonatal sepsis. So the reference was requested from our side for a flagged gram-negative bacilli and blood culture and worsening features of sepsis, any needful from our side, and for antibiotic optimization. After detailed history, examination and lab workup review, our syndromic diagnosis was established as per the neonatology team as well, that it was a late onset neonatal sepsis with septic shock due to hospital-acquired infection, since patient had PICC line in situ, which was removed later on, but it was most likely central line associated bloodstream infection with probable meningitis. At this point of time, we just had information that there was a gram-negative bacilli in the blood culture. So etiological diagnosis remains to be gram-negative bacilli, which is a broad term, but we knew that since it was a hospital-acquired infection, the risk of multi-drug resistance was very high. Since we didn't have time and the patient was deteriorating day by day, something very rapid diagnostic modality was needed. So the best thing we could have done here is to request BioFire, that is a PCR based technology which give you the identity of culture isolate within couple of hours. It is called as BCID, that is blood culture identification system, and can be placed on a flat blood culture blotter. I am grateful to the management that we have such a state-of-art machinery in our hospital. Only second in Rajasthan, other than SMS, we have this machine. So ongoing antibiotics were also reviewed, and the drugs, dosages and route were found to be appropriate at this point of time based on the antibiogram and clinical scenario. So at this point of time, we advise to continue the same treatment, awaiting the BCID panel. Most probable source control was already achieved. The PICC line had been removed already, but there was no other removal source that could be identified in this patient. Within 4 hours of our request, we got the ID of the isolate, that was gram-negative bacilli. It was Enterobacterial family, and the organism identified was from the species of Klebsiella pneumoniae. The advantage of this panel is that we also get to know the resistance mechanism in the isolate, and you can see here we could identify that the carbapinamases which were there in this isolate was OXA48 like NDM, and ESBL was CTXM. So what are these? So major mechanism of resistance in gram-negative bacilli are the production of enzymes which is called as beta-lactamases, which hydrolyzes the incoming antibiotic and render them useless. So they can be classified according to the Ambler classification. So what we identified was OXA48 and NDM. You can see here that they are carbapinamases. So we know that the carbapinam antibiotics are not going to work in this case, or anything lower than carbapinam also not going to work in this case. Simultaneously, we also detected CTXM, which is an extended spectrum beta-lactamase, which would hydrolyze any 4th generation or below cephalosporins as well as aztreonam. So our final etiological diagnosis based on BCID panel was that it was a carbapinam-resistant Klebsiella pneumoniae. Genotypically, it was OXA48 and MBL carbapinamase producer. So how to manage this case? There are two choices which we can take forward. Either we have to add polymyxin to carbapinam, which was already going on in this patient and failing. We know that it was failing, it was not helping. The second choice we could take is, especially in enterobacterials like Klebsiella and E. coli, is novel beta-lactamase inhibitor antibiotics. So we have multiple antibiotics around the globe. You can see the rat suggests inactive and green suggests activity. So ceftalozone, tazobactam, ceftazidime-avibactam, imipinam, cilastatin, rilabactam, and meropenem, viborbactam. You can see here in MBL, none of these antibiotics are going to work. And our isolate was MBL producer. Our isolate was also OXA48 producer. Only ceftazidime-avibactam has some activity, against OXA48, while rest of the newer BL-BLI combination are not going to act there. Cefiderocol is unfortunately not available in India as of now. So what we do, it is an Indian concept that we improvise, what we call as jugaad. We combine avibactam with aztreonam. So aztreonam is a lesser generation antibiotic. It is a monobactam, but luckily it has an activity against MBL. So if we combine avibactam with aztreonam, avibactam would take care of OXA48 and aztreonam will take care of NDM. So in this way, if synergy is there in between them, we can use this antibiotic. To our rescue, since we didn't know that synergy is there or not, from our own hospital, there is a publication recently published in a esteemed journal which suggests, from our microbiology department, it suggests that almost 97% of the isolate of enterobacterials do possess a synergy between ceftazidime and avibactam. So we could have used this antibiotic even without the phenotypic confirmation. So based on the BCID panel report and antibiogram, we advise to stop meropenem and colistin, start injection ceftazidime-avibactam 25 mg per kg with aztreonam 40 mg per kg to be combined together and given in single infusion so that we get the avibactam-aztreonam combination. So this we have done within 4 hours actually. Duration plan was 21 days because we are also expecting the CNS infection, and we had to take the informed consent from the family, and we discussed this with the neonatology team because this antibiotic ceftazidime-avibactam is not approved for children less than 3 months of age. But there are a lot of evidence and case reports which suggest that it can be safely used, and it is very safe, actually safer than polymyxin. So we had to take the informed consent. It was off-label use for ceftazidime-avibactam. We kept the patient in a very close follow-up to look for any kind of side effects as well as the response to the therapy. Thanks to our microbiology team, we got the result, the phenotypic confirmation as well. The isolate was found to be indeed carbapinam resistant as well as ceftazidime resistant, ceftazidime-avibactam resistant. It means it was MBL producer. And we also get the synergy between the ceftazidime-avibactam and aztreonam. In overall, molecular BCID panel shortened the time to action by 36 hours, and it was a major breakthrough in this patient because time in these cases are actually means the patient life is saved. Now to shed more light on this amazing BioFire blood panel, I would like to call upon Dr. Ayushi Sharma, who is Assistant Professor in Molecular Infectious Disease Diagnostic Division. What is?
Thank you, sir. At the very outset, I would like to express my sincere gratitude to our management and leadership for their vision in developing the Central Research Facility and equipping it with cutting-edge instruments like the BioFire Film Array Torch system. It is because of their support that we stand today with one of the most advanced diagnostic platform in Rajasthan. In fact, like sir mentioned, very few centers in the state have access to the BioFire technology, and this makes our facility truly unique. The BioFire blood panel represents revolution in sepsis diagnostics. Traditionally, blood culture takes days to yield results, but with BioFire, we can obtain comprehensive answers in just about 1 hour. Even more remarkable is that the system requires only 2 minutes of hands-on time, making it both efficient and user-friendly. For a cost of 13,000 rupees, clinicians receive a 43 target panel that covers a wide spectrum of pathogens and resistant markers, an investment that pays back in speed, accuracy, and patient outcome. Talking about the workflow, the blood is collected in a BD Bactec culture bottle, which is then incubated with the instrument. Once the machine beeps positive, that indicates growth in the blood sample, which is then transferred to the cartridge of BioFire and further loaded on the instrument. The PCR analysis takes under 1 hour and the report is uploaded on the LIS system. The strength of BioFire lies in its syndromic menu: one test, many answers. Whether it is pneumonia, meningitis, gastrointestinal infection, joint infection, or bloodstream pathogen, BioFire provides a comprehensive coverage. The blood panel alone detects 30 organisms ranging from gram-positive and gram-negative bacteria to yeast such as Candida and Cryptococcus. Equally important is the resistant detection. The panel identifies key resistant genes including MRSA markers, vancomycin resistance, carbamazepines, extended spectrum beta-lactamases, and even colistin resistance. This empowers clinicians to make informed and timely decisions that directly impact patient survival. In conclusion, the BioFire blood panel is more than just an instrument. It's a symbol of how far we have come in precision diagnostics. By enabling rapid and comprehensive results, it positions our center at the forefront of infectious disease care in the state. Thank you. To discuss the further case, I'd like to invite Dr. Kanika Khanna, Neonatology First Year Resident.
Thank you, ma'am. So the final diagnosis is preterm 33-weeker, small for gestational age, with IUGR, with late onset neonatal sepsis, with meningitis with refractory septic shock, with anemia with deranged coagulopathy, with carbapenem resistant Klebsiella pneumonia, that is MDR, and genotypically OXA48 and MBL carbapenemase producer. We started the baby on ceftazidime avibactam and aztreonam on day 8 of life. Vitals over the next 5 days was significantly improving. There was progressive improvement in the heart rate and mean blood pressure, as it is evident from the trend. Serum blood gases also showed progressive improvement, as evidenced by declining lactates and rising bicarbonate levels. Okay, thank you. With clinical improvement, high-frequency ventilation settings could be progressively reduced. By day 16 of life, baby was shifted onto conventional ventilator. Baby was extubated to non-invasive ventilation in one successful attempt at day 20 of life and was taken on room air by day 23 of life. On day 6 of life, baby was in refractory septicemic shock on maximum dose of inotropes, and after starting antibiotics by day 13 of life, we could wean vasopressin as mean blood pressure and perfusion index was normalized. By day 14 of life, all the inotropes were stopped and invasive BP monitoring was also stopped. The serial CBC parameters show significant improvement with progressive rise in the platelet count. Baby remained nil by mouth till day 14 of life. Orogastric tube feeds were initiated on day 15, and by day 19 the baby had achieved full feeds with exclusive breast milk. By day 23 of life, the baby was transitioned to palliative feeds along with direct breastfeeding. As per our NICU protocol, the baby was screened for retinopathy of prematurity. The first screening revealed stage 1 zone 3 disease, and on subsequent follow-up examinations there was regression. We screen the baby for auditory examination is done by Bera, and thyroid function test and neurological examination was done, which was all normal. As part of our pre-discharge workup, we do anthropometry, which showed serial weight gain, improvement in head circumference, length as well as in weight. Ultimately, with good neonatal care, preterm babies catch up in growth. As part of our next is, prior to discharge, the baby was vaccinated with BCG vaccine, oral polio and hepatitis B as well. The baby had also received nirsevimab for respiratory syncytial virus prophylaxis. This is the timeline of the clinical events. Preterm small for gestational age with deranged Dopplers. On first day we had inserted PICC line and started on total parenteral nutrition. By day 6 of life, septic shock developed, and by day 8 we had sent biofire film array panel in which MDR Klebsiella was detected. We started the baby on ceftazidime avibactam with aztreonam. By day 20 there was gradual clinical stabilization. Baby was off invasive ventilation, off inotropes. By day 23 there was spontaneous breathing at room air. Direct breastfeeding was started. By day 29 baby was discharged successfully. Our responsibility extended beyond managing this baby alone. Preventing transmission and controlling a potential outbreak in the NICU was equally crucial. I would like to invite Dr. Major Shilpi Gupta. She is an associate professor from Department of Microbiology to discuss the infection control and prevention strategies which were implemented.
Thank you, Dr. Kanika. To continue with the further proceedings, I would like to discuss what are the infection prevention and control measures we take inside NICU. So whenever we want to do any targeted interventions regarding the prevention and control of infection, we need to know what are the HAI rates of that particular area. As a routine, our infection control team does the surveillance of common hospital acquired infections, which are 4 major types: Klebsiella, COTY, VAP and SSI. So this we do routinely for whole hospital and including NICU. So by the last 1 year of surveillance, we know that in NICU we do not find any cases of COTY, VAP and SSI, but we do have cases of central line associated bloodstream infection. So this is our 1 year trend of Klebsiella rates in NICU. As we can see, the target rate set for NICU is 15.8 per 1000 central line days. The red line, it indicates the target rate, and the blue line indicates what are the actual rates of NICU of our hospital. So as we can see, and in month of April and May the rate was 0, but in the month of June and July, the 2 cases were identified, then in July there was a 1 case, and then we have found sporadic cases, 1 case occurring in September and 1 case, the case which we are discussing, in the month of January. In the past 3 months we have not found any of the Klebsiella rates or Klebsiella infections in NICU. So this was a decreasing trend of infection inside NICU, and it was possible only because of the collaborative approach of the neonatology department and the infection control team. So what do we target at? We basically look about the risk factors which are present. The risk factors inside any critical care area, the most importantly is the presence of lines. The number of lines which are present or which are there in the critical care, it imposes the risk to develop an or occurrence of any HAI. So in terms of care of invasive lines, we do take care or prevent infection by maintaining certain checklists, certain care bundles which are evidence-based infection control practices in the form of insertion and the maintenance care bundle. TPN, as already discussed by the residents, that strict precautions are being taken while the preparation of total parenteral nutrition. It is done under UV laminar flow cabinet. Hand hygiene, considering it very importantly to prevent cross-contamination through hands, so it is being strictly implemented inside NICU. And very importantly, we miss the environmental cleaning. Environmental cleaning is equally important to prevent any occurrence of HAI. So cleaning and disinfection of the surroundings takes place inside ICU thrice a day, and we also focus on terminal cleaning. Terminal cleaning is basically a thorough cleaning which is done after the discharge or the transfer of the patient. So this is the checklist which we follow inside an ICU. This is an insertion bundle checklist. There were certain infection control practices which is followed during the time of insertion, so the infection doesn't enter inside the patient during the insertion. And maintenance is equally important because the line is already there inside the blood vessels, so we need to take care. So during the time of maintenance also the infection doesn't enter. And a random audit is done by our infection control nurses. Then training on hand hygiene is a routine practice. We take on-site trainings including all residents. And as a reminder to increase the compliance, we have this 2-hourly announcement made through e-bags, and I would request it is made for the whole hospital, and every one of us healthcare workers should do hand hygiene whenever this announcement is made. It is just as a form of reminder. This is the environmental cleaning, routine cleaning, and as mentioned, we do terminal cleaning is also taken care of because the bacteria can survive in the environment for longer period until unless proper disinfection is being done. Apart from that, our aim of infection prevention is also that the cross transmission of the infection does not occur. As we have seen in this case, we had this HAI in NICU, but our aim was that it should not be transmitted to other neonates. So what was done was, first of all, it was isolated. We also requested our nursing director to provide adequate number of staff, nursing staff, so that the staff-patient ratio should be maintained as 1:1. Then strict contact precautions in the terms of strict hand hygiene protocol, adequate personal protective equipment should be worn by any of the healthcare while handling the neonate, and we use dedicated or most preferably disposable equipment so that it doesn't get transmitted to other patients. And as a form of reminder, we have this printed poster or placard which is being stuck besides the patient bed as a reminder to everyone who enters inside the NICU so that the contact precaution is taken. Thank you so much. So I would now like to call upon Dr. Arjun Verma, Associate Professor in the Department of Neonatology, to further carry on the case.
Good morning, everyone. Thank you, Dr. Shilpi. As we all have read in our basic, when we were kids, the most famous saying, prevention is better than cure. And ma'am has correctly put that we need to prevent these infections rather than curing them. Yes, we have cured successfully and we are proud about it, but we have to prevent further. The real satisfaction for a neonatologist after working for 14 years and becoming a DM neonatologist is not just about earning money or earning fame. It's about this baby. Now this baby was at 6th day of life. This baby had no fault. Baby should have gone home without any issues. And what landed up was the baby was wrapped up with tubes and wires. And at day 6 of life, for any neonatologist, this is not a good day. And when the baby deteriorated to such an extent, when the pH was dropping to about 7, and that day when we had to counsel the parent in the closed door, and we had to say to the father that we may not be able to make your child survive, and that it is very high possibility that this baby may not see the next day sun. We were trembling when we were saying those words, but we have been trained to calm ourselves and counsel the bad prognosis. At that same time, the father, what he said really will remain in my life for the rest of my days till I'm alive. He said, "Sir, आपको जो करना है करो, भगवान है, बचेगा ठीक है, नहीं तो कोई बात नहीं." And that was his last chance. ऐसा नहीं था. It was not like that he had many other chances to get a second child. So he said that whatever will be the God's wish, I'll obey with that. That itself was a learning lesson. I was about to counsel him, but he counseled me that I have to keep on working for this child. So our team started to dig again to do a relentless exercise. What other antibiotic we can search for, and to remind you, we cannot give an antibiotic like ceftazidime avibactam just left and right in an ICU. It is not. It is an off-label antibiotic. And because of biofire, we had a proof in our hand that this is actually a superbug which will not get treated by cholesterol. We will lose the baby. And because of biofire, because of the infectious disease specialist, we were able to survive this child and see this day. And exactly today, the baby is 4 months old. Baby was born on 13th of January, and today is 13th of May. Baby is 4 months old, and we can see the image of the child on our screen. And this makes our job successful and makes our chest pumped up to work again and again to save these children. And if you see the growth parameters from Bhopal, Madhya Pradesh, the baby has been shifted to their local facility. The weight is 3.2 kg. The baby who was less than 3rd centile at the day of 1 of life is now crossed 10th centile. The length has also improved to more than 10th centile. Head circumference is also more than 10th centile. We had done our job, but I would say the parents have done their job excellent way, so that they have maintained the baby in an absolute normal growth. And you can see a small smile on the baby. And if you see that smile, you can say that it was actually an intact neurological survival, because now we are getting a social smile and a good eye-to-eye contact. That's it. Our job is done. So finally, I would not boast about myself and my team and my seniors. It's a mother's voice is the one which we all should listen to. So this is a small feedback with the due permission from mother.
सीरियल इन्फेक्शन हो गया था और वो सेप्टिक शॉक में चला गया था. उसकी हालत बहुत ही नाजुक थी. हमें तो डर था कि बच्चा पता नहीं बचेगा या नहीं. हालत बहुत नाजुक और गंभीर थी, लेकिन मीको टीम ने हार नहीं मानी. उनकी लगातार निगरानी और समझदारी की वजह से आज मेरा बच्चा सुरक्षित है और मेरे साथ है. उनकी इस उपलब्धि के लिए और मेरे बच्चे को बचाने के लिए मीको टीम को बहुत बहुत धन्यवाद.
So with this, I think I can. There's nothing much to say. This is that the reason why we presented this case is not just about sepsis. It is about the prevention of sepsis, and we need to be very cautious when we work in ICUs for an adequate hand hygiene, because it is the hand that transfers the infection. It is the hand that transfers the cross infection, and it is the hand which is actually a savior becomes a killer. So with this, I thank and give a take-home message as golden hour of management is vital for survival of newborn, that we have been taught in our neonatology training. Supportive management and antibiotics along with inotropes all hand in hand work to prevent infection and to treat the septic shock. For a challenging case of multi-drug resistance with superbugs, not just AST is important, that is antibiotic sensitivity testing. Biofire is now the norm which has to be sent. Remember, it is costly. It takes about 13,000 as a test. But if we save 5 days of unnecessary antibiotics, costly treatment, costly ventilation settings, we bring down the cost to actually less than about 50,000 to 75,000 we are saving from the parent's pocket. So it is not expensive, it is actually economical. Preventing measures and audits are equally important. If one case is there, they can be 100. So we have to bring down to 0. For that, we need proper audits, proper training, and relentless, never dying attitude in preventing sepsis in an ICU. Along with that, this alone a neonatologist cannot save such babies. It is a multidisciplinary team which can save, and it is key in managing a newborn with superbug. With this, I thank the Board of Management for giving us this opportunity, and I sincerely thank Dr. S.S. Jaiswal sir and Lalit Mohan sir for being with us for last 3 to 4 days and spending lot of time, in fact sacrificing their own OPD time and helping us with this CCR. I thank the Department of Microbiology, Infectious Disease, Infection Control Management, Molecular Infectious Disease, and none other than Amrit Milk Bank, because of Milk Bank we are running an ICU, otherwise we would be not seeing this day. I thank Department of Obstetrics and Gynecology, Department of Fetal Medicine, our ENT and Ophthalmology Department, and all the paraclinical departments, Blood Bank, Pharmacology and Pathology, and last but not the least, the nursing, housekeeping and lactation counselors. Because of nursing, housekeeping, we are able to see a clean in ICU with no rates of CLAPSI for last 3 months. Thank you. We end this case.